All right. Hello, everyone. I'd like to welcome you to our Innovation Beyond the Edge program. My name is Jonathan Fritz. I'm the Chief Innovation Officer for Chime. For those of you that are here today, really excited for you to be able to engage on our virtual roundtables. For those listening on the recording, welcome as well. One of the things I wanted to mention is we put this program together the day after HIMSS was canceled and our spring forum was canceled, and really trying to figure out how could we help our members, how could we help the healthcare community in identifying and sharing really what the creative problem solving of healthcare executives is. And today I'm really excited because we've got a unique topic, and we've got a couple of folks that are healthcare IT executives in rural and community hospitals, and they're going to talk about the innovation that they've been doing in response to COVID-19. And one common theme is doing more with less. But I got to say that we've been doing these now for a number of months, and innovation isn't just about bright shiny objects. I'm a recovering patent attorney myself, and I could say that invention is not necessarily innovation, and that you can have innovation by just removing roadblocks, creatively solving problems, and really excited for today. I know that this is a holiday weekend, so really appreciate everyone joining us today. You're going to have to deal with me for a few minutes as a recovering lawyer, and then Tom Stafford, a recovering CIO, before we get to the main topic here with a couple of our members. So what I want to do is just share a screen and talk very briefly about what we've had thus far. We've had about 10, or this is our 10th Innovation Beyond the Edge. And you can see we've had tremendous number and level of presenters that have talked about innovation at large hospital systems such as New York Presbyterian and Northwell in New York and New York State. Also international, Dr. A.L. Zimlichman from Sheba, really fascinating innovation on how they were able to have a zero-touch basically setup of treating COVID patients and utilizing startup company technology, and some children's hospitals and pediatric innovation as well, with Natalie from Stanford and Keith from St. Jude's. All of those are recorded, and we really think that it would be great for you to go to those, review them. A lot of great information there, and you can see the website that you can find them there. So with that being said, told you that I'm a recovering lawyer, so I've got to go through a little bit of boilerplate here. So forgive me on that. We've got three main sections. We're going to have a presentation by two folks today. They're going to be a little bit different than in the past, and tag team that presentation, Brian and Trevor. Then we're going to have a roundtable discussion. So I'll talk a little bit about how that's going to work on Zoom. Probably most of you have had experience with Zoom in the last month or two, like many of us have. And then we're going to do a Q&A at the end. So if you want to put your questions into the chat function, please do, and we can run through that Q&A at the end. So a little bit of boilerplate. We'll have everyone muted during the session. If you'd like to ask a question, put in the chat function. Questions for Trevor and Brian can be posed through that function. I'll ask the questions at the end. And if we have more questions than time, then we'll follow up with answers to that to our attendee list. We're also recording these presentations, so please feel free to review them, to watch them. Chime also has a YouTube channel. They're going to be distributed on that. Although we will not be recording the sessions, the breakout room sessions, so please feel free to have candid conversations there. If you're having difficulty listening, you can call in, but what we ask is if you've called in and you're on your computer, message our hosts so that those can be merged. The reason for that is that when we break out into these breakout rooms, your phone and your computer might go into two different rooms. Lastly, if you attend the full session today, the presentations and the virtual roundtable discussions, you'll earn CEUs, Continuing Education Unit for CHCIO, CFCHE, and CHISL certifications. And we'll review the attendee list following this and distribute those accordingly. So with that being said, I'm gonna hand it over to a good friend of Chime, Tom Stafford, former CIO, I think within the last couple of weeks, maybe. And he's the current CTO, 2 months, all right. CTO for CDW Healthcare. And CDW has been a tremendous supporter, really pleased with the partnership that we have with them. And thank you very much. And I know Dennis from CDW is on the line as well. Thank you, Dennis. So Tom, if you want to take it over.
Absolutely. Let me do the double share. Can everyone see my screen?
Looks good.
Looks good.
Okay. All right, well, good morning and good afternoon, everyone. Thanks for attending what's going to be a very informative webinar about innovations in protecting caregivers, patients, and healthcare staff, and even innovation in IT recovery in the new norm post-COVID-19. Our focus today is innovation in rural and community hospital. In most cases, they have to come up with very innovative ways to solve problems that really the same problems that large health systems have. The main difference is they have less resources and they're also in a very rural setting. So our panel today includes Brian Davis. He's a CIO at Magnolia Regional Health System, and Trevor Clear, the Director of Information Systems at Worcester Community Hospital. Before we get to the panel, I'm going to spend a few minutes talking about the silver lining of COVID-19 and what CDW is seeing from our customer base. There we go. So with that being said, CDW has a very large customer base, and we offer a lot of products and services to support healthcare systems. And during the crisis, we've been able to assist our customers in solving their challenges for COVID-19. And right now, we're hearing and understanding what challenges they're facing while preparing for post-COVID-19. And you know, COVID-19 took a lot of us by surprise. We had to quickly change, scale, and adapt technology. 2 months ago, or I guess 6 weeks ago, I was saying that the silver lining of COVID-19 was telemedicine, but in actuality, it was an accelerated digital adoption. Prior to COVID-19, adoption was always a struggle, especially around digital technology. That's not the case today, and hats off to every IT shop in the country that's been able to deploy technology and support all the hospital's operational needs. The next phase is focusing on innovation post-COVID-19. And here's the demand that we're seeing from our customer base. Innovations in protecting healthcare staff include temperature screening sensors, UV disinfectant systems, sealed peripherals, and these are all around shared devices, and wireless point-of-sale devices and touchless readers. All these systems are being put in place to protect staff by reducing the risk of transmission, and also to create a safer environment for the patients and families that we serve. Innovations in virtual visits have skyrocketed more than anything. These solutions represent the types of virtual visits that exist today, but are also going to exist into the future because we really are entering a new norm after COVID-19. Hospital waiting rooms are being replaced with virtual queuing. In-room patient engagement is finally going to be adopted. I actually think we're going to solve this in the next 2 years. We've also seen an uptick in clinical mobility and studio platforms that provide the right tech to clinicians taking part in telehealth visits. Now more than ever, IT leaders need to focus on protecting patient data. Our endpoint perimeter has dissolved. We're going into cloud more than we've ever been. We've also created all this new technology. And at the same time, the hackers are taking advantage of the crisis with our user base. In addition to that, all IT leaders are either controlling or having to reduce cost. And below are some solutions that you can do to help you with that effort. But enough with me. Let's get into the real meat of this discussion, which is hearing from Brian and Trevor about what they've been doing. And so, Brian, if you could start with and tell us what good, innovative things you're doing down at Magnolia.
All right. All right, thank you, Tom. And thank you all those attending. I hope you find today's content of benefit and value to you and your represented organizations. As Tom said, I'm Brian Davis. I'm CIO at Magnolia Regional Health Center. We're a 200-bed not-for-profit organization, and if the accent hasn't given away already, we're located down in Mississippi. Like many of you out there, being a rural healthcare organization, we want the best for our patients, our community, and our staff. But our first instinct when facing new and emerging challenges is to assess our existing infrastructure and investments to see if we can leverage those in creative and innovative ways to address the situation at hand rather than first assessing what is available in the market space. And thus is why I've kind of titled this presentation, Champagne on a Corona Impacted Budget. Today, I want to take a little time and discuss how we at MRHC utilize our existing investments to respond to the COVID pandemic in order to protect our patients and our staff. Here at MRHC, our largest and most widely used application is our EMR, which is an integrated single medical record solution across our acute and ambulatory facilities. And I've kind of broke the discussion down into 4 topics, which is telehealth, communications, tracking, and intelligence rules. So first off, on the telehealth, we had multiple conversations through the recent years about telehealth and how it would fit in our organization, but we had never really pulled the trigger and made any investments in the telehealth workspace. However, after COVID hit, we knew we had to do something to protect our patients and reduce their exposure risk. So we reached out to a lot of our collaborative hospital friends to see what they were doing, and then ultimately we reached out to our EMR vendor. And in working with them, they offered us a 180-day trial, a free trial of their integrated telehealth platform. So we quickly jumped on that solution. We got the code loaded. We began testing and rolled out to our providers in roughly about a 5-day period. Our providers already carried video and audio enabled devices in our clinic setting, and they were able to leverage those devices to support the product. The solution was rolled out to all 21 of our ambulatory facilities, including primary care, urgent care, and specialty services. The solution has been very successful thus far and has pretty much became our standard of care within our ambulatory setting. One of the real challenges to this type of solution in being a rural health community was the availability of broadband in our area. So kind of to help address this issue, our community, kind of spearheaded by our business alliance, started an initiative with local businesses to open up guest Wi-Fi services within the local businesses to allow drive-up access for school and medical service needs. And then they went and used the social media platforms to kind of get that message out there and to inform the public about these offerings and where they could go to utilize and get free access to utilize some of these services that were being offered. We also realized that we needed to do something on the acute side in order to limit exposure for our clinicians and help preserve our PPE supplies. We're a Cisco Unified Communications site, so we already utilized WebEx for virtual meeting purposes. So we worked with Cisco. We got a BAA put in place and instituted telehealth in our acute setting for our provider-provider consultations, as well as our behavioral health consultations where our providers are remote. We actually had a fleet of iPads with antimicrobial cases that we had already procured for another project. We were able to redeploy those units with WebEx already loaded on them to help and assist and provide these services out to our providers. On the communication front, here in Northeast Mississippi, we've had a relatively low concentration of COVID positive cases. We like to attribute a lot of that to our communication efforts that we've had here at Magnolia. We've sent out automated messages through our patient portal. We created website content, utilized social media, set up a telephone hotline for concerned patients to call into. We've sent SMS messages about precautions. We've placed billboards, and our CEO and CMO have actually done radio interviews concerning the pandemic to get message and information out there. Some of the more innovative things that we did to assist with this communications was that we use an electronic outpatient tracking system here at Magnolia that also performs our patient appointment reminders. We were quickly able to modify our appointment reminders and begin sending out information around visitation policy changes, precautions, and then just general visit preparedness for those patients coming in. Secondarily, we also leverage this system to limit our patients' time in the clinic setting for those patients that did not qualify for a telehealth visit or had a needed outpatient procedure. So upon arrival, they were checked into a virtual waiting room that allowed them to wait in their vehicle. And then when their modality or room was available, they would receive an SMS message with instructions on how to proceed to enter the facility. Also, on the inpatient side, during the no visitor period, we wanted to help our patients be able to communicate with their families. So we distributed iPads out to our inpatient units with FaceTime and Google Duo loaded that allowed them to do patient-based communications with their families. This was another area that we kind of ran into some challenges with. When we reached out to our vendors to procure the devices, these iPad devices, our suppliers weren't able to meet our needs. And so we got on the phones and contacted a lot of the local retail outlets, and within roughly a 75-mile radius, and we're able to source the iPads, and we sent people out to pick those up and purchase those. On the tracking front, we actually built, in our acute setting, we built some surveillance dashboards that were utilized to easily identify patients that had been tested for COVID. It showed that if their labs had been resulted, whether they were negative, positive, or if they were still pending. Likewise, on the ambulatory setting, we created a Koban Registry that was used to track patients that either had a positive or a pending test. And this was intended to be utilized as a quick real-time list for staff to reach out and check on those patients that were in isolation and see how they were doing. We also began tracking and screening our employee temperatures and health upon entrance to the organization. So we developed a health screening tracker database that we built internally here that utilized feeds from our HR system that allowed the checkers to do badge scanning to kind of streamline that workflow process for them. On the intelligent rules front, kind of another challenging area for us was that we had a limited supply of tests and treatment options available to us and supplies. So we worked with our EMR vendor, and we built out rules within that system to limit who could order tests. Additionally, if a provider was not on the authorized list, it gave them guidance. They would get a message on guiding them how to get those tests performed and kind of the appropriate treatment and ordering process for them. So that's a quick rundown of kind of some things that we did here at Magnolia. And so now I'll turn it over to Trevor so he can talk about what they've done at Worcester.
That was really, really impressive. So thanks for handing it off. And it's also very interesting to hear that we've done almost very, very many of the same things. There's a tremendous amount of preparation here at Worcester Community Hospital, 176-bed community rural hospital. So I'd say small to medium. Same with you, Brian. We're completely vertically integrated on our EMR. We're also a Cisco shop for telephony and messaging. We did a large amount of preparation, but at the same time, we had to be very, very mindful as we went along. Being smaller, being more rural, there was a lot of focus on community confidence, not knee-jerk reactions or not, I guess, pulling too many levers, too many triggers too quickly. The big players, if you remove or if you assess a lot of the data in the community for COVID-19, the big cities, the big systems up on the lake here in Northeast Ohio or at the Capitol have much different experiences than we have here in rural Northeast Ohio. So we had a very measured plan, and we exercised that plan. We didn't throw up tents immediately, but we were prepared to do so immediately. We threw up an incident command center with SharePoint for lots of over communicating. A great social media presence. So what we have here is a nice picture from Worcester Community Hospital's social media site, demonstrating and trying to provide that confidence to our patients that our disinfectant procedures are top-notch and that we take things very, very seriously here. If you go to our website, if you go to our Facebook page, you'll find an FAQ about how we keep our patients safe, how we clean our rooms, and how serious we take it. You'll find a lot of pictures of our personnel wearing masks and holding signs and saying how important the community is to us. And so the community is very proud of we're a municipal hospital. It's a government-run organization. And so a lot of pride here in Worcester. And we take that very seriously and continue to reach out to our patients. And the bottom line here is don't delay your medical care. I mean, there's a real life example where a patient was in picked up by the bus and said, please don't take me to the hospital. I don't want to get COVID. I don't want to have coronavirus. And he was having chest pain. And so, you know, it was a lot of explanation to say, no, this is actually the best place for you to be in your circumstances. And there is no reason for you to fear having coronavirus. And so we too have taken a lot of the same measures that you've taken, including telehealth in every possible way. Perfect transition, Tom. Thank you. We were a little earlier on the board for telehealth, having partnered with AmericaWell and producing a product called Today Care, which is very, very low cost way of assessing a physician here and or through AmericaWell. Immediately, just like you, Brian, we contacted our major partners in healthcare software, and we purchased or took opportunity with the patient portal telehealth licenses that were offered, and that's been very, very successful for our providers, both with web ambulatory and then on down the line, all the acute side providers want to do the same thing, and so they have all been enabled with webcams. And if you've been playing along in the market, finding webcams has been a major challenge, and so we had to get a little creative, and we had to reach out and find displays. You know, think not just focus on the webcam that I'm looking into today, but we set up these studios similar to what Tom was saying, with one large display with built-in speakers, microphone, and display, so that the providers could communicate with Zoom video conferencing for those acute visits and those acute follow-ups. We've gone through cardiology, surgery, behavioral health, PT/OT, speech therapy, lactation, dietary, all the way down the gamut for telehealth. Teleworkers, this translates right into teleworkers and the model of teleworking, sending people home to keep the hospital safe, to keep our patients and at one time visitors safe when they arrive. Enabling ways to use personal IT, enabling secure ways for personal IT. Secure Link is for remote desktop control, VPN, to have access to all of the resources here within the network. And it was a very timely implementation of VDI infrastructure. So at the same time we were implementing all of the nurse units on a virtual desktop with tap and go functionality, we were able to exercise remote connectivity with VDI, where the providers had the exact same user experience for their desktops here in the hospital. Very closely on the heels of 2FA and secure access with VDI came, how do we dictate? And so Dragon PowerMic Mobile came along, and that almost immediately went into the house. So, we have power mics, which are a costly device at all the provider workstations, and providers quickly found that I would rather use my own phone. And it was used very, very successfully and adopted pretty quickly. Maintaining collaboration with all of our teleworkers, providers, wherever they are, was increasingly important. When you can walk down the hallway and talk to somebody or sit in a conference room face to face, a lot of people were a little hesitant to turn on their video cameras and be seen. A little side note today, I'm wearing my Slick Vans shoes here under my desk. I have my Zoom shoes on today, I call it. Nobody can see my feet. People were a little hesitant to turn on their video cameras, but once we did, immediate increase in collaboration. So video conferencing, tremendous improvement, and also a patient safety and employee safety factor. Last thing on this list is policy. So we get caught up, and there's a lot of regulation, and we get caught up in policy, and it's usually the very last thing we want to do, and it's the least liked thing that we want to do in our job. But immediately we looked to our security risk assessment vendor and got some templates for teleworkers, for telehealth, produce policies and produce procedures for enabling and how a request is given, and how quickly, what our service level is to provide that support, to provide that license, to provide that access. Next slide, sir. For patient safety, we also did video visitation, iPads on every nurse unit with FaceTime and Zoom. Virtual rounding, we have carts that roll through the house where a hospitalist or any physician here in-house or remote, sometimes at their office, can be in a room with a patient. An early and I think a pretty good idea from our patient-facing folks was remote registration. We pulled registration out of the ED, put them in an office next door to the ED, and they do everything with video conferencing and telephones. Like Brian in Mississippi, we implemented a large number of surveillance boards, and with that, a lot of policy around them. Who can see them? There was a great concern over when our staff start to become infected, and how are they going to be seen on these boards, or will they not be seen, or who will see them? So we implemented different boards for employees who have been tested and or are positive. Visitor tracking, we developed our own visitor tracking database. Patients came in through very limited entryways. Were screened by staff from various other places in the hospital who maybe had been furloughed, for lack of a better word. They'd be given a pass and they could be placed into this database, and they would appear at the nurse unit who would check them in, and they would know how many visitors were with that patient that they were there to see. And at that point in time, it was 2 at once. It reduced to 1, and almost within a week. I don't think it took a week until we eliminated visitors in the hospital. Like Brian in Mississippi, I think we have a total of 17 cases that have come to the hospital, been hospitalized. So the forecast was far, far higher and far worse than it really was. And so we're looking at a very measured response to re-enable visitation. It's important for patients to see their friends and family. It's a very significant improvement in recovery to have visitors. So we see that, and we want to keep maintaining that. We have hands-free payment for cashiers and for the gift shops and for cafeteria. We do allow, of course, the card, but we're cash. But we highly encourage the use of just your Apple Pay, for instance. For organizational safety, we implied, and Tom spoke to it here, there's still a lot of opportunists in the market, and so they're trying everything they can to take advantage of any dropped guard. And so we implemented a new SIM during the COVID-19 pandemic. It was hard to do, but we got that up very, very quickly, just like the patient portal implementation for telehealth. I think it was within a week we had a new SIM standing up to diversify our security. We did a phishing test, and this may be viewed as not fair by many of you, but we phished our email for every employee and every physician in the organization with email from the CDC and from Zoom to sign up for your new Zoom account. You might estimate that our success rate was pretty high on that one, and it was. And so it offered another good opportunity to educate that there are still opportunists in the market trying to get data or trying to breach our borders. You guys are very familiar. I don't have to tell you about how difficult budget season is. Whenever your budget time comes around, all hands on deck, you drop a lot of things and apply yourselves to the budget. We did it again. So during COVID-19, we went through an entire new budget season for capital and operating, reassessed everything we'd already asked for. In an IT capital, we dropped $210,000 of capital, just postponed it. Other things were postponed till later in the year. It's financial stewardship to push those things out when your patient volumes and revenues are cut significantly. Just today, turned in the operating budget that demonstrated what we're going to do as an organization. We've asked all of our partners in the market to also participate in these kinds of reductions. Worcester takeaways. Community confidence is huge, and we need to be very measured, and we took slow steps. While we're looking at Italy and while we're looking at New York and while we're looking at the bigger places, we assessed ourselves where we are and how we are. It involved a lot of data capture, a lot of trending, a lot of surveillance, and a lot of stewardship. Next step in that is really we're going to go full force if we can with barcoding every supply, either zero charge or the chargeable items. Our mission, part of our mission, the first phrase in our mission is to be accessible. And so that was the full force push toward adoption of the EMR, and that meant telehealth. We also reached out to our community businesses. We know that they have employees, and they send their employees to us when they're ill, but they want to be tested. And so we have started offering testing to the community businesses for their employees, and including antibody testing. Interesting statistics are that the positive ratio or the positive rate of testing is minuscule, but it builds confidence in the community. Community and patient awareness, employee assurances and confidence. We want all of our employees to recognize all of the efforts we make, including what's coming next week is a automated kiosk for in the lobby, I guess, right inside the door, scanning and screening for temperatures with facial recognition. Eventually, within maybe a month, if things continue to go, again, this is a measured step, we want to integrate that with our door security systems, where you may not be allowed into the hospital if you have any of these symptoms, otherwise if you have a temperature. I talked about our difficulty finding webcams and changing to displays. Communication, we implemented alert media so that everybody gets notifications as quickly as possible in real time of the needs at the hospital. SharePoint, social media, video and telehuddles, and instant messaging, all of which had to be policy driven. So a great amount of work in a very short amount of time. And it wasn't all IT innovation, I think, as Jonathan noted. It was really innovative thinking in lines of operating a healthcare system in an area like Worcester, Ohio.
Wow.
Hope I got through that in time.
You did, absolutely.
Right.
So thanks, Trevor, and thanks, Brian, for talking about some amazing things that you guys have been doing. And obviously, a struggle in all communities do this, but the community confidence thing definitely is really resounding, and I know Brian was probably feeling the same thing. But now at this point, we're going to transition to the breakout sessions. And I have this really cool graphic, but I think we're going to do a little differently today. And I'll let Jonathan take over from here.
Thanks, Tom. Appreciate it, Trevor and Brian as well.
Okay, well, I got a question for all of you, because the one thing that I saw was absolutely amazing during this crisis was the accelerated adoption of digital tech. And that happened more than anywhere around virtual visits. And I thought back, and when I was a CIO at Halifax Health, in January, if I would have walked up to a hospitalist and said, hey, not even in 2 months, you're going to sit in front of a video screen at the nursing station and have a conversation with a patient in a room 50 feet away. And you're going to want to do that. And the reason why you're going to want to do that is to conserve PPE, to not have the time to put the PPE on, and also just to reduce your risk of transmission with a patient that has COVID-19. And so obviously everyone wanted to do it, but still folks had to be trained because it was new technology. So did anyone have any training struggles introducing virtual rounding or telehealth, telemedicine, or was it pretty smooth? I mean, the numbers you see where people went from 30 visits in a month to 300 a day is outstanding and astounding. But did anyone have major struggles, or was it pretty quick to convert everybody over to virtual visits?
Well, just as you said, the level of sort of pushback for that in the past may have been one way, and suddenly it was, we had a cardiologist who's sitting at home going, I'm not coming in. You have to connect me to that patient in the room. I'm not coming in. And so that was an interesting dynamic. So we obviously had to come up with that solution. But I think it was mentioned earlier, I'm not sure it was Brian, but from a leadership point of view, the whole idea of how quickly governance structures have changed and how processes that would normally take weeks or months or years to get through were settled in hours or minutes in some meetings. It is a real important go forward for us. Is why do we put processes in place that make it so hard to make these decisions, and yet we can make them when we need to? And so we really need to go back from a leadership point of view and say, why did we put these barriers in place, and how can we make sure we learn from this about how to avoid those things going forward?
Say, Tom, I've got a question that follows up on what Gerald was saying, is that we've seen throughout all of these innovation beyond the edge that like you mentioned, that months are days, years are weeks, and you've got leaders that are putting forth some really innovative solutions to problems. How do you sustain that? And I'd be interested to hear from Trevor and Brian of how do you sustain that with the partners and allies internally, so that your organizations don't fall back to the way they were before and taking such a long time to solve those problems. Trevor or Brian?
Yeah. I think ours is, the community, our organizational leaders witnessing the changes and the effectiveness of them, and leveraging those quick wins that we've put in place to say that, this can be done. We can do these things. This bureaucracy behind the scenes I mean, there was some things from a legislative thing, CMS, executive orders that assisted in us being able to roll these things out. You know, we're on the Tennessee border, and we do a lot of Tennessee visits. We have a lot of patients out of Tennessee. So executive orders out of Tennessee allowed us to do some things that we have not been able to do in the past. So there are some other things, some overall, but I think just leveraging those wins and keeping those communications going and open and showing that we can be effective is kind of is utilizing those wins to help.
And Jerry, you brought up an important point before was, can we sustain this, right? So the velocity of change and even the approval of the change was so fast, and obviously it was very beneficial. So, I mean, it'd be incredible as a CIO if we could maintain that moving forward. And, you know, instead of literally we would be able to take the next 10 years of what we were planning on doing and adopting technology to help, you know, care for patients, that could be, you know, brought into less than a year. So hopefully that will sustain. Do you guys feel it's possible, or do you feel like once COVID's over, we're going to kind of go back to normal? Or are you trying to protect this new process that was created?
I have to hope that the payers are going to step forward and continue with their support of telehealth, because prior to this, it was really slow. I can't imagine them taking it back. I would hope that the heads that they cover, so to speak, are going to desire to continue to use, you know, these conveniences of telehealth. Having experienced it, like you said, at high velocity during the pandemic time, they'll have a good taste from what it's possible to continue doing this. And so if they all of a sudden continue to use telehealth and their payers say, oh, I'm sorry, you know, that was elective, you're going to have to pay for that by yourself, and there's enough complaints about that, you know, assuming that the payers take it back, maybe that'd be a way to sustain it. It's going to have to start from there. It's regulation, right? It's CMS is going to have to continue on. I think it was today, maybe yesterday, I saw some loosened regulation around digital pathology, and that's another after effect of COVID-19. And so if these bureaucracies can loosen up their grip and allow these technologies to go forward, I think the patients, I think the providers and the organizations will be very willing to sustain the use of it.
Yeah, you brought up a very good point. And obviously, the adoption around the administrative side of healthcare was a lot easier because we were getting paid for these visits. And if it seems as though that the genie's out of the bottle, I heard from the ONC, and that essentially telehealth is here to stay, and there's a lot of benefits to it. And so I think it's very possible that's going to continue. And I cannot remember which payer it is, but it was out of Tennessee, and they said they're going to continue to pay for telehealth after COVID-19's over. So there is some good movement in that direction, and I think in the end it'll make healthcare better overall.
I just sent the link for Blue Cross Blue Shield of Tennessee in the chat.
Oh, is that the one? Okay, yeah, I thought I saw that. So that's good, right? So if the Blues start doing it and everybody else follows, and then if CMS obviously does it, then it'll help it sustain forever, hopefully. But the cool thing for everybody on this call is, like, you guys did some amazing stuff in weeks that should have taken months, possibly years to do. And so hats off to you all, and protecting our communities, and to providing the care that our patients need, no doubt about it. So thank you, Trevor and Brian and everyone else on the call that's been participating.